Hello, everyone. First, I just want to say I think the introduction can maybe hopefully be looking into the future. I'm actually a PhD student right now, so I'm not yet a doctor. And I'm also coming from Moffitt Cancer Center and not NYU, but hopefully it's the future. But today I'm going to be presenting on, can I get the notes view?
She's asking for presenter view so she may see her notes.
Thank you. So today I'm going to be presenting on dreaming big, thinking about ASCO guideline concordant oncofertility care for AYA patients from the perspective of the allied healthcare professionals and the people that are actually looking at or taking care of our patients. So I want to start with the background when thinking about are highlighting key ASCO recommendations that are actually outlined specifically for the role of the healthcare provider. So the first is all oncologic healthcare providers should be prepared to discuss potential infertility as a result of treatment and potential risks or potential fertility preservation options. And then when patients who express an interest or those who may even be ambivalent, those should be referred to fertility preservation to talk further about fertility preservation options and to receive those services. All discussions regarding fertility preservation options should occur as early as possible, preferably before treatment, because as we know, treatment can impact fertility. And patients should be referred to psychosocial providers, especially because news like this can potentially cause distress about their infertility. So the role of including psychosocial providers is very key. And then finally, to encourage patients to participate in registries and clinical registries. So when thinking about allied healthcare professionals, allied healthcare professionals include, but are not limited to nurses, nurse practitioners, social workers, genetic counselors, psychologists, PAs. But as shown in the literature, and has become abundantly clear to me over the past couple of days, that these allied healthcare professionals, they play a crucial role in the provision of care for AYA patients with cancer. So while oncologists might be treating the disease, the allied healthcare professionals are often the ones that are providing health education information, the psychosocial care that kind of influences their decision-making and their future quality of life factors. So these people are very important in the care of these patients. So ASCO guidelines actually extend the responsibility for fertility preservation to specifically include allied healthcare professionals. So in thinking about that, in general, research to kind of explore provider awareness and adherence to ASCO guidelines has been limited and is somewhat dated. There was a study that was published, I think in 2009, that showed that out of approximately 60 oncologists who reported awareness of ASCO guidelines, less than 25% actually reported following the guidelines on a regular basis in their care of patients. Others have found that among oncologists who provide care to pediatric patients, only 44 were familiar with ASCO recommendations for fertility preservation. So thinking about the important role of allied healthcare professionals in the care of these patients, and despite the ASCO guidelines kind of suggesting that allied healthcare professionals should also be responsible for providing this kind of care, allied healthcare professionals are not being trained adequately, and their perspectives in providing this care are not actually being considered when it comes to considering guideline concordant care. So to that end, there we go. Sorry about that. So despite revised guidelines, there has been limited attention to training allied healthcare professionals. So to that end, the purpose of this study was to explore alignment between ASCO guidelines and allied healthcare professionals, their desired plans to improve oncofertility care within their institutions. And what better way to do that than to look at data from the ECHO program. So as many of you likely know, the ECHO program is an annual web-based training intervention for allied healthcare professionals to communicate timely and relevant reproductive health information to their AYA patients. To date, the ECHO program has trained over 700 allied healthcare professionals over 6 cohorts from 2017 to 2023. The main learning objectives are to refine and implement the ECHO program over time to facilitate knowledge and skills that these allied healthcare professionals are gaining to address reproductive health needs for the AYA oncology patients via a web-based learning community, to evaluate the impact of the program at the learner level and also at the workplace level, and to develop a network of trained allied healthcare professionals to share experiences, resources, and dissemination of program and content. So for this program, participants are actually asked to complete a Dream Big assignment. And in this assignment, they're asked to kind of describe an ideal case scenario for providing optimal care for fertility preservation care for their patients. So a part of this assignment, participants are asked to develop their specific goals that they'd like to accomplish within their institutions, detail some action plans, include specific tasks, persons responsible for the tasks, any necessary resources, indicators of success, evaluation plans, to kind of map it all out to have kind of a plan that they can leave the program with and then therefore go to their institution and hopefully improve oncofertility care there. And this is kind of a sneak peek into what the assignment actually looks like. So for this study, what I did is I conducted a content analysis on the Dream Big assignments for cohort 5, which took place in 2001. All the coding was guided by key ASCO recommendations for healthcare providers and extended to allied healthcare professionals. And we ended up only including participants who completed the program, those who actually completed the assignment, and those who provided care at an NCI-designated cancer center or comprehensive cancer center. And the reason we did that is because NCI-designated cancer centers, they get a significant resources towards developing research programs and facilities that'll lead to better innovative cancer approaches and things like that. So really wanted to focus on that for this, but I do recognize that that could be a limitation. So preliminary results. A part of cohort 5, there was 174 total participants that completed the program and the Dream Big assignments. For the purposes of this analysis, we included the Comprehensive Cancer Center and cancer centers, of which there was only 63. Majority were from comprehensive cancer centers. When looking at gender, majority of the participants were female. Profession was pretty evenly spread, with the most being nurse practitioners, but profession was evenly spread across these different types. In average years in profession and average years in oncology, there was quite a large range, but the averages were around 11 and 8 years, but the range was from 1 anywhere to like almost 30 years. And then overall, 15 states were represented in the 63 participants included in this analysis, with most of them from Texas. So about 16 were from Texas, 15 were from California, and 11 from Tennessee. So when thinking about ASCO guidelines, what we did is we looked at the overall goals that participants said that they wanted to implement within their institution, and then went and looked at their action plans. So when thinking about initial discussion of risks to fertility and fertility preservation options, of the 63, 43 actually really emphasized the importance of initiating discussions around these topics. And when looking at the action plans, a lot of the healthcare professionals said that they needed systems for prompting providers to actually begin the discussion. So maybe a checklist in the EMR, or maybe something on the front end when the patient is being checked in, but some sort of system should be needed. Provider requirements, this one was actually interesting. There's only one of these, and they actually said that they need to include it within the provider oncologist contracts, that they are required to discuss fertility preservation and incorporate it into their institution's health policy. And the last one was patient-provider education. So of the 19 that talked about patient-provider education, 17 of them were about provider education, because oftentimes these participants said that their oncologist didn't feel comfortable about initiating discussions. They felt like they didn't have enough knowledge to do so. So they wanted to bring more educational materials to their institution. Timing is very key for fertility preservation. 12 participants mentioned that timing should be considered when they're trying to improve their services. Referral to REI, 33 of the 63 discussed that, and again, when looking at action plans, systems for referral pathways, which include EMR most of the time, and same thing for psychosocial services. 12 of the 63 mentioned it, and only one of them mentioned how they wanted to do it, and it was via EMR for a system for referral pathways. And then finally, participation in clinical studies and registries. No one mentioned that, but just thought it was important to point that out. So some key notes that I wanted to, or quotes that I wanted to point out. So for the initial discussion, one participant said, every new patient with cancer diagnosis will have a discussion with a member of the Oncofertility care team regarding diagnosis and or treatment impact on fertility. My goal is for providers seeing patients in my clinic to have a conversation with any patients starting systemic oncology treatment for the first time and have conversations about fertility preservation. With timing, I would like all AYA patients' reproductive health needs are addressed as soon as possible before cancer treatments are started. With referrals to all newly diagnosed female patients referred to fertility specialists within the first week, so that also kind of aligns with timing a little bit. Additional goals are created to automatic referral processes within the current EMR system so that any patient or survivor who falls within the young adult age range will be sent a consultation for the young adult psychology and fertility services. So this kind of bleeds a little bit over into the psychosocial services. And the final one, our goal is to create standardized processes for fertility clinic team to access psychology support, intervention for patients seen in the fertility clinic. So a lot of the participants thought about all of this, but when looking at all of their assignments, there were a few notable themes that came out that weren't exactly related to the guidelines. So the first was definitely funding and costs. So funding and costs was around whether it was insurance coverage or whether it was funding to help patients receive fertility preservation or about storage after they receive fertility preservation, implementing infrastructures and mechanisms within their institution to help their patients with funding and costs was a big thing. But then also thinking about funding for the institution itself to potentially have, different groups of people, working groups and things like that, that could actually focus on this specifically. Another thing that came up was sexual health discussions. I know we talked a lot about that yesterday. So a couple of the participants only focused on sexual health discussions as their goals for their institution. Patient support groups were pretty large as something that they wanted to implement in terms of patients needing to have community, patients being able to reach out to each other locally, whether they needed transportation help and things of that sort. And then finally, the creation of multidisciplinary teams was a pretty big thing that came across, and Oncofertility services in nature is a multidisciplinary field, so a lot of them expressed the need to have these teams in place, but then also to have a point person who is solely dedicated to this program. So efforts to increase guideline concordant provision of fertility preservation in patients with cancer is essential. In looking at all of these Dream Big assignments, the study highlights that allied healthcare professionals' goals to improve oncofertility care within their institution aligns with ASCO guidelines. Pretty much all of the 63, except for 4, mentioned at least one guideline in their recommendations. So allied healthcare professionals can really provide key recommendations to inform future interventions on improving the provision of guideline concordant care. So some of the main things that came up were systems to manage appropriate referral pathways, mechanisms to increase patient and clinician knowledge about fertility preservation, collaboration between multidisciplinary care teams, and measures to ensure equitable access for patients and timeliness. And in looking at all of these assignments, the other thing that kind of came to mind is, the last time the ASCO guidelines were updated were 2018. So, maybe in the next iteration, including allied healthcare professionals on the committee to talk about the next update could be helpful because, they're talking about needing to talk about sexual health and things like that. So maybe considerations of updating guidelines the next time could be useful because we can add things like sexual health discussions to it. But I know that is my time, so just wanted to say thank you. Wanted to say thank you to Dr. Quinn and Dr. Veda-Parampil for allowing me to play around with the echo data, and thank you all so much for allowing me to speak today. It's been a wonderful couple of days, and any questions?
Thank you. Are there any questions? We are at the hour. Yes, Dr. Liv.
Hi, I'm Olivia of Cincinnati Children's. I'm a patient navigator. So I'm kind of using this as like a plug more than a question. But that was fantastic. I think we all have to, we've had so much great information thrown at us from the science, from the bench, and all those things. But we bring up that point of really having that, unified kind of integrator that is supporting the team and being able to speak to the multiple divisions that make up your program. I'm putting in a plug-in for the navigators, but I want to say this: a navigator looks so many different ways, as you have stated, and please feel free to use this group, even if you don't have an official navigator. Reach out to us. It's not that you have to be that to be a part of this committee, and I think it's important for everybody to use our group and pick our brain so that we can help you get that support. Because if we don't have that person, none of this stuff is going to happen. So just a plug to reach out to us. We are open and always willing to help, as you guys know, as this whole community.
Yeah, to your point, when looking at the assignments, it was very clear that all of the participants knew the ins and outs of exactly how care was being provided, where the gaps were. So these are the people that really are facilitating, adequate care to be given. So including them in the process, I think, is just very important.
So thank you, Liv, for your comment, and thank you, Sarita, for your presentation. That's the end of our morning session. Let's give a round of applause for our speakers. If the speakers could stay, we need to take some photos, and then the rest of you may take a 30-minute break for posters. And we'll see you back at 10:30.